Alright, hi everyone, I'm Newt, and today I'm going to be talking about the applications of lipid emulsions in clinical toxicology. And so I just listed some objectives here. The purpose of this was for me to learn more about this, and to my goal is to present the utilization of lipid emulsions in clinical toxicology, to recognize when these should be initiated, to be familiar with some of the proposed mechanisms of action, to describe some of the dosing considerations, and to understand the rationale for its use and some of the limitations. So first off, this is an overview of intravenous lipid emulsion. Traditionally, it has been used as a source for parenteral nutrition. It's also used as a diluent for IV drug delivery of highly lipophilic drugs such as amphotericin B and propofol. Currently, it has been explored to be used as an antidote for local anesthetic toxicity, and it was first studied as an antidote for bupivacaine, especially for rodent models. It has been successfully utilized and documented in several human case reports. And beyond this, it has also been explored for use in other pharmaceutical overdoses and toxicity. And these have been mostly performed in rodent models as well. And there are documentation of use in human cases as well. And I will go further into this as we move along in the presentation. So what is intravenous lipid emulsion? It's a lipid solution of two types, the triglycerides and phospholipids. And mainly soybean oils and egg phospholipids are the ones that are found in the preparations. You can see there that these are available in the 10, 20, and 30% solutions, but the one that has been studied and documented for use is the 20% solution. This is delivered by IV administration through the peripheral or the central vein. So now for one of the application of use is in local anesthetic toxicity, so I will go over a little bit on local anesthetics. So its therapeutic use is to provide analgesia through topical application, by injection into the vicinity of the nerve endings, or through instillation of the epidural or subarachnoid space. And how it works is it makes the area insensitive to pain by inhibiting the nerve conduction, and does so by binding reversibly to the receptor in the sodium channels. And you can see from the image there that it does so on the intracellular side. Some of the agents there's two classifications, the amides and the esters, and the properties of these agents can determine the toxicity with the local anesthetics. And here are some of those factors. So regarding properties, how these local anesthetics are metabolized can play a role in how much toxicity they can cause. For the esters, they are less toxic because they're more rapidly hydrolyzed and eliminated in plasma. Whereas with the amides, they have a greater potential for toxicity because they go through liver metabolism, which will be slower. Other properties of the local anesthetics include fat solubility, tissue protein binding, and then next is the serum concentration. How much is absorbed correlates with the level of toxicity, and thus the administration parameters such as the dose, the rate of administration, and the site of injection can play a role as well. The acid-base status of the patient also plays a factor, as acidosis can potentiate or amplify the effects of the toxicity. So what are kind of the manifestations of these toxicity? The primary target organs are the brain and the heart, because these are the organs that are highly perfused and they have the sodium channels. For CNS manifestations, you can see dizziness, nausea, agitation, disorientation, tremors, loss of consciousness, or seizures. With cardiovascular side, they can block the sodium channels, as mentioned earlier, as its mechanism of action, and so these can relate into some of these manifestations: the decrease in blood pressure, bradycardia, wide QRS, bigeminy, the pulseless electrical activity, ventricular tachycardia, and asystole. So next is looking at the management of local anesthetic toxicity. And so the main line is to provide good supportive care. And this is through airway management, seizure suppression, basic and advanced cardiac life support. They do mention that avoidance of high doses of epinephrine should be done, avoiding vasopressin, calcium channel blockers, and beta blockers, or any type of agents that decreases cardiac contractility. So the indication for using lipid emulsion, it is not a FDA approved use, so it is classified as an unlabeled indication. However, there is evidence that is evolving, and so it supports the use of this when there's a threat to life that isn't imminent and other therapies have been ineffective. As I mentioned earlier, the 20% solution is the one that is utilized, and the trade name is the 20% intralipids. Of note there, propofol cannot be used as a substitute because this can will result in an overdose if it is done accordingly to the recommended dosing. So here are some of the evidence for the use in local anesthetic toxicity. It has been first explored in animal models, specifically in rats with the bupivacaine. Related to human case reports, there have been 22 peer-reviewed case reports from the year 2006 to 2011. It demonstrates the successful use of and documentation of these in several cardiovascular collapse cases. In a recent report, the lipamic report, which was published in 2014, this is a report that investigators reported any cases that utilized lipid emulsions into a database from August 2009 to 2012. And the reports showed 10 of the 48 cases were related to the use of local anesthetic toxicity. And in these cases, the main toxicity was CNS manifestations, and all the patients who were utilized this lipid emulsion therapy survived with no complications from the therapy. We do have to note the limitation with these, since they are case reports, with the potential for any biases for its publication of favorable results. So here's the dosing recommendations. Per the ARSA, or the American Society of Regional Anesthesia and Pain Medicine, they recommend that initial dosing should be done with an IV bolus of 1.5 mLs per kilogram, done over 1 minute, and then followed by a continuous IV infusion of 0.25 milliliters per kilograms per minute. They have an upper limit, which is 10 milliliters per kilogram over the first 30 minutes. And then other considerations that can be taken is a repeat in bolus once or twice if cardiovascular collapse is persistent. And then the infusion rate may be doubled if the blood pressure remains low. For the duration, they mention to continue the infusion for 10 minutes after stability has been obtained, and to have a prolonged monitoring after resuscitation is successful for over 12 hours period. Here are some of the possible mechanisms of actions that has been proposed. The major one that has been talked about is the what is termed the lipid sink model. And this is the idea that by administering the lipids, it provides this phase where it can drive the toxic drugs from plasma and tissue into the newly created compartment. And basically, so it sequesters these toxins away from the target organs. Then another proposed mechanism of action is the fatty acid metabolism theory. This is proposed because the anesthetics may block the transportation and oxidation of fatty acids, which is the preferred substrate for generating ATP in the heart. And so by providing this source of energy, this can overcome that impairment. Other proposed include the activation of ion channels. I mentioned that the mechanism of action is blockade of sodium channels, so a way that it can work is to decrease the induced blockade as well as activation of calcium channels. The other ones listed there include being a positive inotrope as well as having an effect on the carnitine transport, which in a sense will help to improve utilization of fatty acids. So besides utilized for the local anesthetics, it has been looked and explored for utilization in other toxicity with other pharmaceuticals. In human cases, the toxic database reports 9 cases with drug-induced cardiovascular collapse, where 5 of these patients who were treated did survive. From other reports, they report over 55 cases of improvement after use. And here are some of the listed drugs that have been associated in those cases. This includes some of the antidepressants like the TCAs. There are some antipsychotic, anti-seizure medications, the beta blockers and calcium channel block, and then some of the other medications as well. And so from this, some of the researchers, they state that the current data provides possible benefits for use in overdoses of TCAs, bupropion, lipophilic beta blockers, and calcium channel blockers. Again, the limitation here is any potential biases that are reported, effects from other therapy utilized in that resuscitation or during that process, and any co-ingestions. So for some of the considerations for use in the non-local anesthetic toxicity, there are no specific indications. The other therapeutic options, like the mainstay treatments, should be utilized first. When can these be used? Well, they may be considered when lipid emulsions may be used when patients present in extremis or when they're at that point of death and other options has been exhausted. There's the question of, so if these lipid emulsions provide benefit, what about using it earlier on in the process? Well, some data and some animal models suggest that early administration can lead to an increase in toxicity. And this is because of the potential for increasing GI absorption or facilitating the distribution of these lipid-soluble agents throughout the body. And so dosing in these toxicity with the non-local anesthetic, there are no standards again for that have been established, and so the recommendations are similar to those to the dosing used in local anesthetic toxicity. And this I listed there again is doing the IV bolus initially, followed by the infusion, and then repeat boluses if necessary. There have been some case reports of prolonged administration, and a potential use of this is because the non-local anesthetic medications may have a longer duration of toxicity. In the case report that I looked at, it dealt with a severe amitriptyline overdose, where the patient had a recurrent cardiovascular collapse. And what they did was they did an initial bolus of 250 milliliters, and then was followed by a 100 milliliters per hour infusion. And they did this over the course of a day. They did discontinue therapy, and then instability recurred, and then they reinitiated the second day. They then stepped it down to an 18 milliliters per hour infusion for a period of 17 days. Of interest is to note that these doses are much more than some of the recommended doses. The patient did survive, and they mentioned in the study that they are still alive today, so it shows a potential for the prolonged administration. With adverse effects from this, the main one to take note of is the egg allergy warning, since the egg proteins are in the formulations. So for those patients who have egg allergies, this might present with a hard decision. So it's up to the clinician who's taking care of the patient to the side of its best interest in the patient to be utilized. Besides that, safety remains a concern because of the given limited in case reports and no clinical trials. And so some of these potential adverse effects are may be caused by the lipid infusion, may be associated or just reported with those cases. And so these include, of course, allergic reaction, including anaphylaxis, fat emboli, pulmonary hypertension, thrombophlebitis, pancreatitis, interference with laboratory testing such as in the BMP, CBC, and LFTs, and then fat overload syndrome if larger doses are used or if they do rapid infusions. And so that comes to the conclusion and looking at what are the clinical implications of utilizing lipid emulsions. It shows that it's a possible option for use in certain toxicities, especially the more data available for the local anesthetic toxicity. There's less clear evidence with the non-local local anesthetic toxicity, but it still remains a reasonable option if all other therapies fail. We talked about some of the proposed mechanism of why this might work, and that includes the main one, which is the lipid sink model. And then we talked about some of the dosing considerations, which includes a bolus and infusion, and how there's no standards established for the non-local anesthetic toxicity. And we just have to be aware, if we are utilizing this, to be aware of the potential adverse effects that can occur. And so here are my resources. And that comes to the conclusion of my presentation. What questions do you have?
Nicely done.
Very good. Good.
Okay, we'll talk. So questions. So I have several. Go ahead. You sure? Okay, so first, name, this is more for Ed. So what are, just give me an example and then I'll follow up with the question. Like the top 2 things you've recommended it for.
Calcium channel blockers.
Okay, then that's for one. Are we, it probably doesn't matter, let's say calcium channel blockers. Is it due to the fatty acid then, because that's more on the heart, or lipid sink, or it doesn't matter? Like, in other words, what's it doing?
It's probably both.
Both? Okay, so it's sort of part of its mechanism of action. And to follow that up, this extremis, I get that, but it reminds me of, a little bit of leave a fed, leave them dead. It got this bad, how do you evaluate, I guess it's a larger question, evaluating effectiveness of something when they're dying anyway, for lack of a better question? So that's one.
You have a,
So
I think it's hard because of how, I think the most clear evidence you can see is when, for example, like that case when they did the extended prolong, is they exhausted every option, and every time they did everything, like for example in that one, the QRS was prolonged even after doing bicarb and doing every other options for resuscitation. And once they did the lipid emulsion, the QRS basically narrowed, yes. And then once they discontinued it, widened again. And so I guess it's only one case that demonstrates that out of the few. I'm not sure all the details of all the other cases, but there's a lot of variables that play in the factor of seeing how, if it's really that or is it kind of a combo or things like that.
Well, and you can see then an effect from that.
so to get a little more towards your answer, how do you evaluate this better? You're basically stuck having to do high quality, which means very expensive animal studies with dogs, usually some bigger animal, and then going through the various permutations and having the dogs well instrumented and getting a lot of data from them before you then jump forward and try to make other recommendations. If you take a look back at the high dose insulin for calcium channel blockers, very high quality dog experiments led to the idea that, okay, maybe this is, has some good science behind it.
Okay,
Probably be the same thing.
same thing.
Yeah.
'Cause, yeah, this really, there's a lot of things I didn't know here.
Is that a
I
project
didn't
you want to start,
understand.
Dr. Zellmer?
Yes, go, because I had Go for it.
Is it something you would do with anyone who's an extremist, or do you really want it to be one of these things they have listed? I mean,
If
There's-
they're about to be dead, it's worth
what I was
trying.
gonna say, they're
So
gonna,
pretty much any drug overdose that you can think of.
okay,
Most of the time, they're going down the tubes with calcium channel blocker,
Yeah.
bupropion, a tricyclic. Those are the ones I can think of
Right.
that we've used. Those would be totally reasonable. Oh, the diphenhydramine. The people who are dying 8 days out from their acetaminophen, of course, not useful. That's all. But
okay,
acute stuff, it's worth trying if the option is they're dead,
okay.
provided they don't have an egg allergy.
This month, oh, sorry.
Well, if they have an egg
Yeah.
allergy,
That's right.
You may
Yeah.
make them dead.
right.
So this much bigger doses.
Mm-hmm.
I don't, not on the phone's enough. What's our usual? It's over here somewhere.
Yep, the usual doses
Okay,
on the-
It's
so
easy.
this guideline, is this the same you use recognizing local anesthetic? Are we using the same? It's kind of the same for
Yep.
whatever you're using it
Yes.
for. It's not just local anesthetic. Okay, so for all use, if you will. Okay,
But realizing you may have to go way above that in our side, in the toxicology side, or the non-LA side.
more,
Yeah.
bigger doses.
Right.
Oh, okay. May need bigger doses.
Mhm.
Okay, and then, you mentioned, esters less toxic because goes through liver metabolism. What do the amides do?
They hydrolyze rapidly in the serum.
Oh, okay, so they don't go through that, okay. You probably mentioned that, or it's down here, but, okay. I'm good for now, if you,
I thought that was the other way around.
Or
The esters hydrolyze, and the
Emulsion.
amides have to go
oh, you
through-
said amides go
And I-
through metabolism, so
Yeah.
esters
Yep.
Mhm.
hydrolyze in
Yep.
the serum. Okay, you did, I wrote that. Okay. I misspoke here, okay. Some others probably before I. Good, so it's very informative.
It was good.
Are they getting, just simply a pharmacy question in a hospital, are they getting permission, like it's not an FDA approved drug?
I saw like there's like a website like I think it's Lipid Rescue or something, and they talk about like creating like a kit so that it's like in the placement where they have these procedures being done, and so if it's necessary, it's kind of it's the
Right
kit is set there. Yeah.
Okay.
Mhm.
And then I guess the last thing, is there something else this is stuff's used for, like it's been around forever and we're,
TPN.
TPN,
Yeah,
yeah.
they get it.
that's what it seemed
Yeah.
like. It
Usually
is
you get
TPN.
TPN every
I've
day, and
been
then like
so out
every
of
3
it.
days you get fats or whatever. They
Right?
usually, yeah.
Cause
Yeah.
I keep thinking,
that's what they use
it's
it
been
for.
around for what,
Yeah.
TPN?
It's been in
Hello.
shortage though, so
Yeah.
it's been kind of difficult to get. It's in shortage.
What's in shortage, okay, okay.
So I mean, you could, there for a while, all the 250 bags were out, you can't get them, you can only get the 500s, vice versa, but you couldn't get 10% any longer. It's a pretty standard 20% 500 ml bags are the only bag you can get.
Okay, wow, okay.
There for a while.
Why did
We
we
didn't
know
be
of
in those
this
glass
Yeah,
therapy?
bottles.
we
Is what
did
they
do
used to
fats
be.
on TPN patients because we couldn't get it. We
Oh,
reserved just for
Okay,
emergency situations.
Oh, wow.
so that would
Yeah.
be in play here. Okay, so it's still used the same way?
Yeah.
TPN, okay.
Yep.
Yep, okay, for the life engineers, how do we know about this? I mean, just the term, okay. How do we-
You had mentioned propofol, can't use it. Not only cannot you use it because of propofol, it's only 10% intralipids. What is the other trade name for these? Intralipids is one, what's the other one? I can't think of what it is. Is it lipocin or something like
Lipocin, I
that?
think. Yeah,
Lipocin.
lipocin.
Okay. You mentioned about intralipids as the trade name. I think that's because that is the one that's been used the most in these case reports, as opposed to having a bias towards one or the other. It's just an experience issue.
So let's,
And then also, another thing on propofol or Diprovan, you're looking at another allergy there too. You're looking at peanut allergies as well.
oh, I didn't know that. With Diprovan?
There's a couple different brands. that-
So are they all in a
Right.
peanuts solution or whatever?
No, just a few of them.
There are, okay. Okay. Okay, that's what I had, so. Okay, very good.
Interesting.
Mhm.